Hello, my name is Pedro Cunha. Today I'm presenting my thesis project in the doctoral program in physical activity and health. My title is Effects of Resistance Training and High-Intensity Interval Training on Body Composition, Physical Fitness and Quality of Life in Patients with Chronic Lymphocytic Leukemia. My investigation team is constituted by me, Pedro Cunha, and by José Carlos Ribeiro, my supervisor, and Ricardo Jorge Ribeiro, co-supervisor from E3S Lab of Genetics from the FMUL. I will also count on physical activity tasks with Andrea Pizarro and Maria Paula Santos, and hematology and oncology tasks if grants are considered and we are able to take blood samples. Those investigators from the E3S will help to see the variables regarding blood analysis. From the hospital, we have Inês Carvalhais and Ana Carneiro, medicals from the Department of Clinical Hematology from Hospital São João, our neighbors. From the background, I can say that insufficient physical activity is associated with non-communicable diseases like cancer. It is well known that active living has been positively engaged, but some concepts remain unclear. For example, regarding the FIT principle in prescription, frequency, intensity, time, and type of exercise. Chronic lymphocytic leukemia is the most common form of leukemia in Europe and United States, typically occurs in a median age of 70 years old with a slight male predominance. Nevertheless, it has been shown that the proportion of patients with early stage disease is also increasing, which means that younger people are being diagnosed. CLEL is characterized by the clonal proliferation and accumulation of mature B cells within the blood, bone marrow, lymph nodes, and spleen. As observed in other B cell malignancies, the survival of CLEL cells strictly depends on a permissive and nurturing microenvironment, which produce various cytokines, angiogenic factors that interact with leukemic cells via surface receptors and restrict or makes their survival or aggressiveness more On the other hand, the immune response against leukemic cells is compromised due to cytotoxic T cells, exhaustion, and a defective immunological synapse formation with antigen-presenting cells. Also, we have natural killer cells showing a functional defect with reduced ability to lyse CLEL cells associated with lack of cytoplasmic granules and impaired immunological synapse formation. Higher levels of self-reported exercise, physical activity, and cardiorespiratory fitness are inversely associated with the primary incidence of several forms of cancer. In general, exercise is a tolerable adjunct therapy associated with significant improvements in the control of several cancer and treatment-associated symptoms. The associations between physical activity and risk of hematological cancers are available in the literature, yet conclusions are variable. In one study, we found that higher levels of exercise were associated with reduced risk of myeloid neoplasm, CLEL, and mature B-cell lymphomas, but not plasma cell disorders. Several studies evaluated the feasibility, safety, and clinical impact of an exercise program, even when severe anemia and thrombocytopenia were present, so exercise can be used in these groups. In mature B-cells neoplasm include CLEL patients. Aerobic exercise has had positive effects on cardiorespiratory fitness, fatigue, self-reported physical functioning, and quality of life. The effect of resistance training is also positively correlated with attenuation of bone loss, musculoskeletal function, and one repetition maximum strength. High-intensity interval training is a very new type of training. It's a short training, but with high intensity, and it has shown persistent effects on muscle strength, cardiopulmonary function, and quality of life and fatigue in cancer survivors, with superior effects when compared with traditional treatments. In this table, I show the main studies that have been made with CLL patients. This line of investigation started in 2002 with only some minor body composition and other parameters measured, and only by applying questionnaires. In 2009, the same line of thought were made. In 2012, it was the first intervention protocol with this type of patients, but only 4 patients were trained. It's a very, very small group. 2013, again, only questionnaires, and only recently, by 2020, 2021, is that investigators start to look for other implications of exercise in CLL patients. In 2021, one of the references study is from McDonald. In this test, he made exercise protocols, pre-evaluation. He made body composition and other parameters of body composition. He evaluated lifestyle with a wrist-based accelerometer, and he implemented an intervention protocol, a training program 3 times per week during 12 weeks. This intervention was with high-intensity interval training alone. By other investigations, Stillinger, exercise protocols evaluation were a little bit smaller. Okay, he used more field tests to analyze the patients. Body composition and other parameters also using field tests, and he only applied questionnaires. So in the literature is a very large gap in implementing protocols of exercise. And for us, the strength intervention is also very important in these groups, because in CLL we have an impaired activity physical fitness, and the loss of muscle mass and the loss of bone mass is associated with CLL patients. So our aims are to first characterize the physical aptitude, cardiac and respiratory tests, characterize the physical aptitude and physical activity patterns of CLL patients. We'll use cardiac and respiratory tests, strength tests, and body composition for the physical aptitude, and accelerometry and questionnaires for the physical activity patterns and clinical evaluation. Our hypotheses to identify the benefits of high-intensity training in CLL patients include hypothesis 1, strength training contributes to higher gains in muscle mass. Hypothesis 2, combined program delivers better results than isolated programs. Number 3, if overall quality of life is increased independently of the exercise program in comparison to control group. And hypothesis 4, physical activity patterns are increased during and after protocol intervention, with CLL patients becoming more active. Of course, we want with this study to consolidate knowledge about general population prescription in CLL patients, also verifying the feasibility of the 3 types of protocols. The HIIT protocol with interval training in ergometric bicycle, the strength training with machines with weights, and both protocols. We want to see if both protocols are better than isolated programs. As strengths of the project, This study will assess effectiveness of a high-intensity training, a resistance exercise program, and a combination of the two in the psychological and physiological variables in patients with CLL. So it's a novelty. We don't have many strength training in the CLL patients, and also HIIT training are a very small group of tests by investigators. So we only have one study. In my knowledge, we only have one study using HIIT training in this group of CLL patients. We'll conduct a randomized controlled trial with crossover, which means that we have a group divided in 3 subgroups. One group of 20 persons, we estimate a group of 20 persons to participate in the HIIT training, 20 for the resistance training, and 20 for the combined training, and 60 from the crossover. And our protocol I will talk about a little bit later. Using standard outcome measures, we will use some of the tests that are very used, are in great use by scientific community. We use DEXA, we use ergospirometry, we use isocinetic for evaluation of strength. So we use many machines, many protocols that are scientific approved. The exercise program is developed based on existing evidence and consists in both strength and HIIT training. It's a novelty in a study. The exercise programs are considered to have a higher potential to restore muscle mass compared to moderate intensity. It's what literature says about other cancers, breast cancer, colorectal, lung cancer. And we expect an improvement in the physical as well as the psychological health status of CLL patients. So that's why we will apply also to inquiries, to questionnaires about this area, psychological, clinical factors normally evaluating quality of life. We also have in this project the counseling sessions in invited hospitals. So when a patient is making our protocol, every time he experiences anything bad, anything that is not comfortable with, he can ask for counseling with his doctor, Ana Carneiro or Inês Carvalhais, or talk with us and try to manage the symptoms that he is getting from the protocols. As possible handicaps, we know that the number of participants and commitment, assiduity during the study may be a problem. I leave this question in the air for everyone that wants to give an opinion. Perhaps the possibility to include another variable of supervised distance training. I know that making HIIT training it's not easy. In this case, we don't have a personal bike to offer to the patient, and also strength training could only be based on small weights or TheraBands. It's not the ideal of our study, but maybe it's an option. I don't know. I will wait for your opinions. Also, training discomfort and intensity adjustment can lead patients to leave the study. Of course, in this case, every prescription is based on baseline evaluation, so we will not start on higher intensity grades that are not supported by our patient. We will construct his physical fitness gradually. Motivation must be held, stimulated by the instructor, of course. It's a HIIT training. He needs to get into higher intensities, so instructor must be constantly motivating the person. Continuous patient information for me is very important. Every time a person know what he's doing and what purpose is is and for what purpose is he doing that. It helps to keep the motivation high. Of course, we need to keep this information focused on heal improvement. He knows he have a problem, he has a disease, he has a cancer, so we need to keep the information focused on heal improvement. Of course, in this case, we don't know how many persons will enter in our study. Participant number may be too low because patients, in our case, are not in the medical discharge situation. If we get persons between 45 years old and 75 years old, we may get persons that are working still. So to make to attenuate this problem, we will try to diversify as much as possible the available schedules. This timeline is a prospect of what we are intended to do. Of course, from the early 2023 to middle 2024 is where we will get our data, our tests, and our intervention protocol, and we expect to deliver at least 4 papers. One that is already been prepared, we will try to submit in the beginning of 2023 with the literature review that give support to this investigation. Another paper is also being prepared with protocols description. Next, when we're beginning to get data, we want to make the characterization of CLL population about quality of life, physical activity, patterns, body composition, physical aptitude, as long as we have data, of course. And the last paper, the protocol implementation and the data analysis about that protocol. It's what this study is intended to do. About exercise intervention. Patient enrollment will be recruited in onco-hematology consultation in participating university hospitals. Patients must have a confirmed CLL diagnosis with age between 45 and 75 years old and willing to adhere to an exercise program. Of course, they will sign an informed consent. Exclusion criteria: the person cannot be in CLL treatments, chemotherapy or other therapy. Engagement in regular exercise program indicating the starting treatment as also cannot have. And other primary tumors, eventually, if you have inability for performing exercise, is also an exclusion criteria. For our study, we will have 16 weeks of resistant exercise, 16 weeks of high-intensity interval training, and 16 weeks of combined exercise resistant and HIIT. These 3 groups will have their trainings consecutively. Okay, it's not a 16 plus 16 plus 16. No, they start as soon as they have the first evaluation of physical aptitude. Of course, we'll have a non-exercise control group that after 16 weeks will cross over. I want to get your attention in this case, as we are talking about a possible treatment that may increase the make the healthy of the health of the people, the patients, better. We don't want to withdraw the treatment from the first patients. So in the time of crossover, with the data that we already possess, if this data is statistically significant and we have a positive reaction to the intervention group, there will not be a truly crossover. The first group of interventions will stay in the intervention group, and the control group will pass to the intervention group as also. So we will not deny the treatment that is doing better to our patient to make the crossover. Regarding body composition of functional assessments, at each time point, the first time the person makes an evaluation, at crossover and at the end of his protocol, we will evaluate cardiac and respiratory evaluation, anthropometric and body composition measures, maximal exercise test on cycle ergometer, and strength evaluation in the upper strength and lower strength. There is no evidence that level of medical supervision required for this type of patients must be different from any other populations. Nevertheless, we will have medical vigilance and all the instructors participating will have a course of basic sport of life. I don't know if it's the correct form of saying. Physical activity patterns are objectively assessed by accelerometry with GT9X link through 7 consecutive days with minimum of 10 hours of daily assessment, and also to inquires FACIT F and EORT quality of life C30, C30 and CLL specific for CLL 17. As exercise protocol prototype, we have 3 groups of intervention. Resisted exercise training will always have a warm-up 5 to 10 minutes. Next, we'll have 8 to 10 resistant machine exercise for the major muscle groups, leg press, leg curl, leg extension. We have all described in there. Performed in 2 sets at 80% of REM to stimulate the hypertrophy of muscle mass with intervals of rest of 60 to 90 seconds. During the first 3 weeks, we'll have an adaptation period, and after that, we'll start in the protocol. We will progressively increase the load as needed. In high-intensity interval training, we'll also have a warm-up. Next, the patients will start with 4 intervals of 30 seconds at 85% of maximum heart rate with 1 minute rest between sets. And sets will increase 1 set per week for the first 3 weeks. In week 4, we'll be carrying out 7 intervals of 30 seconds with a minute of rest in each interval. Each 3 to 4 weeks, additional intervals could be added according to patient's response until reaching the maximum of 12 intervals. We only have 16 weeks of intervention. In the resistant exercise plus HIIT, we will have the same protocols, but with the same population also. In this case, we will achieve 2 + 2 sessions that will be alternated between HIIT and resistance, assuring non-consecutive days of training for the same protocol. Controls will receive only the advice to follow their habitual physical activity routines and will be contacted bi-monthly to assure participants' retention to the study. Protocol will last for 16 weeks with 4 sessions per week, ensuring a 24 hours period rest. Session will be monitored with heart rate monitors all the time. As medication could induce heart rate alterations, we will also use RPE, perceived exertion rate, to control the intensity of the training sessions. The intensity control will be conducted by the exercise technician, in this case me, directed by the supervisor, of course. Finally, about ethical issues, we are talking about human participants. Of course, they need to be volunteer and capable of giving informed consent. Blood samples may be collected. This part is not yet fully established, but may be collected. So patients will be advised with this routine. But in the medical center where they are receiving the consultations, they also give this analysis, give this blood for analysis. So it's not a different method that the one that is used by the hospital. To ensure patient confidentiality, of course, databases will be blinded in the computer specially located for the project. And also, as I already talk about, after the 16 weeks, which will undergo the crossover, if the intervention process results to demonstrate statistical and biological relevance for the participants, the crossover will not be performed for the benefit of the patients, and the same exercise intervention protocol will be applied to all the groups. Also noted that this project already have the approval of ethics committee of the Centro Hospitalar Universitário de São João. Thank you. Suggestions and comments right away.